We'll talk about DKA or diabetic ketoacidosis. Diabetic ketoacidosis (DKA) is a medical emergency. It is an acute complication of diabetes mellitus, especially type 1. There are three cardinal features: hyperglycemia, hyperketonemia, and metabolic acidosis. Coming to the pathology, the patient has uncontrolled diabetes. So, there is no insulin in the body. When there is no insulin, three things happen. There is increased gluconeogenesis, increased glycogenolysis, which both contribute to hyperglycemia. Along with that, the no insulin state produces increased lipolysis, which increases ketone bodies. So coming to this hyperglycemia, there is glycosuria, that is, there is increased glucose in the urine, along with osmotic diuresis. The increased lipolysis produces increased ketone bodies, which produces acidosis. So both glycosuria, which causes osmotic diuresis, and vomiting produces a loss of water and electrolytes, which finally leads to dehydration. So in elaborating that, this insulin deficiency can also contribute with glucagon excess to form hyperglycemia. So glucagon excess, which is not always present, along with increased catecholamines and increased cortisol, which are stress hormones, contribute to hyperglycemia. And this leads to osmotic diuresis, dehydration, as said earlier. This dehydration causes hemoconcentration, hypovolemia, and hypotension, finally causing decreased renal perfusion and oliguria. At the same time, this insulin deficiency can cause ketosis, along with the increased catecholamines and cortisol. Also, increased lipolysis, as we have seen earlier, will cause ketosis. This increased lipolysis leads to increase in free fatty acids in the body. This will lead to formation of new ketones in the liver, that is hepatic ketoneogenesis. As a result, there is accumulation of acidic ketone and there is metabolic acidosis. Due to this metabolic acidosis, there is increased hydrogen ion entry, which displaces potassium. This potassium loss in urine also causes vomiting. So the average loss of fluid in DKA is 3 to 6 liters. 50% is from the intracellular fluid and the rest is from the extracellular fluid, which includes plasma, blood, etc. So due to the dehydration, this causes hemoconcentration, hypovolemia, oliguria, decreased renal perfusion, hypotension, which also causes complications, as we'll say in the future. Precipitating factors for DKA include inadequate insulin therapy or non-compliance, infections like pneumonia, sepsis and UTI, cerebrovascular accident like stroke, MI, acute pancreatitis, drugs like steroids, cocaine, olanzapine, clozapine and thiazides. Clinical features of DKA, which include three main headings. It can be due to hyperglycemia, due to dehydration, and due to metabolic acidosis. Coming to clinical features due to hyperglycemia, there are three main things: polyuria, polydipsia, and weight loss. So these are the initial symptoms. Later, as the hyperglycemia worsens, lethargy, focal deficits, and obtundation occurs, which finally leads to coma. In addition, there is blood vision due to hyperglycemia. Coming to the second point, due to dehydration, there is loss of skin turgor, sunken eyeballs, dry tongue, cracked lips, tachycardia, and hypotension, along with cold extremities and peripheral cyanosis. Due to metabolic acidosis, there is Kussmaul's respiration, which is a key feature when a patient is presenting to the OP or the emergency. Kussmaul respiration, which is a deep and sighing breathing, the main feature is the acetone smell in breath, but fetid smell. Nausea, vomiting, and abdominal pain is present due to metabolic acidosis. The abdominal pain may be due to ileus. Other feature includes signs of the underlying precipitating illness. Now coming to investigations of DKA, we can check for the blood glucose levels, which will be surely higher than 250 mg per deciliter, along with arterial blood gas analysis shows metabolic acidosis. The plasma ketone bodies is raised. Urea and creatinine is raised due to severe dehydration. Electrolytes, low potassium bicarbonate and low bicarbonate is seen. The sodium levels can vary. Urine analysis shows presence of sugar and ketone bodies. ECG shows variation due to MI or abnormal electrolytes. Serum amylase and lipase is elevated. Infection screen is done. Total blood count, differential count, blood culture, urine culture, CRP and chest x-ray to find for any precipitating causes. Diagnostic criteria for DKA. It includes blood glucose for more than 250 mg per deciliter, arterial pH less than 7.3, serum bicarbonate less than 15 milliequivalent per liter, and moderate degree of ketonemia. Management of DKA can be said in 6 headings.